Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And I always tell you that this is your show, and there must be something special about one of my guests because he's breaking a record today. You know, we've been at this for almost 2 decades, believe it or not, and there are very few people that have been on this show as many times as my dear friend and what a wonderful doctor, Dr. Nicholas Tranakas, sitting right in front of me. He's a oncology surgeon with Broward Surgical Associates, I think it is,
yes.
Right? And Dr. Tranakas is so well known in our community, not only for his capabilities, but for his advocacy and for his, what I would call his true soul. So, Dr. Tranakas, welcome. Welcome back.
Well, thank you for the invite.
Good to have you. And someone who I've just met, Dr. Tracey Stokes, who is a cosmetic restorative surgical individual, surgeon, but she does what you would generally call plastic surgery. And she's with eSSe, I think. Is that correct?
You got it.
Plastic surgery. And I'm sure that you have a lot to do with breast cancer surgical patients and other reconstructive areas. Thank you very much for being here.
Thank you for having me.
Good for having you. Dr. Tranakas, I know we're going to be talking a great deal about what Dr. Stokes does, but you know, there's so much happening in the field of cancer, cancer therapy, cancer diagnosis. You want to touch on a few of those things?
Well, a couple of things. First and foremost, every person needs to know what their risks are for certain diseases, especially when it comes to cancer diagnoses. And what I'd like to say is, first of all, you got to choose your parents wisely, because a lot of what we have is what we inherit from our family members. Second of all, once we assess risk, we have to figure out what is the best way to be able to intervene early and make early diagnosis of all of these diseases, whether it's cardiac disease, cancer, diabetes, etc. And as far as the field of cancer detection and diagnosis is concerned, the best thing that we have is our newest technology in terms of imaging, where we can actually find these cancers before they become problematic, where we can deal with them with less surgery and probably with less treatment after the surgery by way of types of chemotherapy, more targeted therapies these days, where we can diminish the number of symptoms and side effects of those treatments and hopefully attain much more cures.
And there's so much interest, and we'll get into this later on in the show, but there's so much interest in this new, what I would call immunotherapy, the new gene locating techniques and things of that nature. We'll talk about that. But it has, I think it has revolutionized not only the issue of oncology, but many other areas of medical, shall we say, professional works.
Oh, absolutely, and especially with your new institute now with cancer research here at Nova, we are looking at more targeted therapies, whereas in the past we used to say, okay, we have this medication or this drug that's going to be effective against this particular cancer. And now we've gotten down to that molecular level where we can actually see common pathways amongst different types of cancers, and we can target that particular pathway and have one drug that is going to be more targeted to those cancer cells and affecting less of our normal cells, while at the same time being effective against different types of cancers. So now we're looking at medication that's going to be effective against different types of cancers rather than pigeonholing each medicine to a particular type.
Dr. Tracey Stokes. One of the issues that our viewers always talk to us about, and it's a very difficult area to talk about, because most people, when they think of dominantly breast cancer, they think of the years or the decades of their earlier life with, you know, double mastectomies, et cetera, et cetera, et cetera. And I'm just topically getting to it. But now we have not only early detection, but we also have new methodologies for reconstruction. So why don't you tell us what you do and what's involved?
Absolutely. So I'm a plastic surgeon, and I specialize in breast surgery. Part of that is reconstructive breast surgery after a woman has had a mastectomy, like you said, for cancer. And some of that is cosmetic breast surgery. We are in South Florida, so a lot of people get augmentations, lifts, and cosmetic surgery to look better. I am a big advocate for women undergoing reconstructive surgery after a cancer diagnosis. And the field of reconstructive breast surgery is expanding ever readily. So as techniques are advancing for breast cancer surgery and becoming less and less invasive with lumpectomies, so are the reconstructive techniques improving.
A good portion of care in oncology is the recognition of the fact that one in our society is sort of believing that they've been damned, that they've been cursed. How could this happen to me? But you have to make them aware of the fact, as Dr. Tranakas says, in the very first sentence, he says, you have to choose your family. Well, there is a genetic disposition to all human species and all really species on Earth. But the reality is that individuals have to know that compassion goes along with good professional skill. And in the field of reconstructive surgery, whether it be breast reconstruction, we had a program just a few weeks ago on birth anomalies in children. Well, it's understanding, it's the communication with the caregivers, the spouses, the loved ones, the partners, whoever it is, for them to understand. And that must be a big part of reconstructive surgical procedures, I would assume.
Absolutely. I mean, half the time I describe myself as a therapist with a scalpel. Women come in, I am a woman. My mom had breast cancer when she was 40, so I can relate personally to a lot of the patients and their stories and their caregiver stories. And a lot of it is hand holding and helping them through this difficult time. What's so great about what I get to do is I get to be the ray of light. We talk about hope and reconstruction and making things better and restoring the patient to whole again through different surgical techniques.
And of course, the human spirit is contemptuous to anything that disfigures them, that offers a sense of not being well, and you have to work through that.
Of course,
Correct.
Not being well, not being whole, being different from everyone else. How can I go out? Everyone's going to look at me twice, whether I go to the grocery store or not. And restoring a patient's self-confidence really is beautiful, because once someone has that confidence to go out in public and just be themselves, that confidence really is beauty.
I give a lot of credit, and I think, Dr. Tranakas, we discussed this on one of our shows, the multiple shows that you've been in, is that I give a lot of credit to people that are well-known, actors, actresses, entertainers, people in government or otherwise who communicate their issues relative to breast cancer, relative to colon cancer, relative to many different things, cardiac disease. And it enables the people who view the show and multiple other people to say, wait a minute, if that particular person is willing to talk about it, why am I not communicating with my doctor? Why am I just trying to hide something? Do you find that often when your patients come in?
Well, yes. I mean, even in the field of breast reconstruction, like we're talking about today, there's what's well known as the Angelina Jolie effect. When Angelina Jolie got tested for BRCA, which is a gene that gives you a genetic predisposition to get breast and ovarian cancer, and decided to have prophylactic bilateral mastectomies and a risk reduction oophorectomy, many women started asking for the test. I'm sure you see that in your practice.
No, absolutely. And as those kinds of stars, become more public, or the public awareness about these diseases also increases, and that also spurs more research, and more research leads to better outcomes. And again, the breast cancer issue is the best example of that. We have so many different targeted drugs now just for breast cancer than we had even 5 years ago. And I think it comes from that approach.
Let's stick with that, Dr. Tranakas, because the two most communicative issues that our viewers talk to us about are breast cancer. When we talk about cancer, is breast cancer, colon cancer, and prostatic cancer. Those are the three, not two. Dr. Tranakas, I know of your advocacy with the American Cancer Society and others. This got to be it's a revolution.
No, absolutely. And for those three diseases that you mentioned, with breast, colon, and prostate, at least for the first two, we have made tremendous progress. Colon cancer is the most preventable cancer that we have. We can actually cure that and actually prevent it from even happening by having your routine colonoscopies and taking out those polyps that are going to be precancerous polyps that will lead to that colon cancer. So the most preventable cancer that we have, I can tell you how many people do not go and have their routine colonoscopies done when the recommendations are made to do so. Breast cancer, if you're considered to be in a high-risk category, we actually have 2 FDA-approved drugs that can help prevent 50% of those breast cancers in those high-risk individuals. And then for those patients that are carriers, as Dr. Stokes said, with the BRCA gene, we can offer prophylactic surgery. And with that prophylactic surgery, although it can be disfiguring in the past, with people like Dr. Stokes and their reconstructive techniques, restoring that body image to their normal, then takes away a lot of that stigma of actually intervening and preventing those cancers from happening. Prostate cancer, unfortunately, we cannot prevent it at this point, but we can certainly be able to identify it early enough where we can then still have better treatments and better cure rates. And nobody has a higher risk for prostate cancer than the African American community. And I can tell you how many people do not have their routine screening with PSAs, digital rectal examinations, and visiting their physicians on a routine basis.
And I also know, and you touched on it early in the program, about the new, I guess you could say, diagnostic radiographic and scanning opportunities. You want to touch on that just a bit?
Sure. When we talk about screening tests, the screening test has to satisfy 3 good criteria. First of all, it has to be readily available. B, it has to be relatively inexpensive. And C, we have to be able to screen a good part of the population in a relatively short period of time. Currently, when it comes to breast cancer, the best screening test that we have, despite a lot of the controversy that you hear in the literature and in the press, is a good screening mammogram. But it has its limitations. So because of that, we've developed better techniques with the 3D imaging that we have on mammography. We also have the contrast-enhanced spectral mammography that kind of almost equates to a poor man's MRI, where if we do find abnormalities on the routine screening mammogram, we can do these other less invasive procedures and tests to then minimize the number of times that we have to do biopsies. And so the number of biopsies when we do them truly is for cancer diagnoses rather than for just not knowing what this thing is, and the only way to figure it out is to do a biopsy.
Right. So, Dr. Stokes.
Yes.
I also know that there's that you, in your reconstructive area, there is also something called air expansion processes.
Yes.
You want to explain what that is?
Sure. So in this day and age, approximately 100,000 breast reconstructions are done a year. 3/4 of those, or I guess a more precise number would be about 77,000, are 2-stage reconstructions with tissue expanders placed at the time of the mastectomy that are later exchanged out to permanent implants, silicone or saline implants. I was lucky enough to be part of an FDA clinical trial for a new type of tissue expander called an aeroform tissue expander, and the name of the company that developed this expander is called AirXpanders. With a traditional saline expander, It is placed at the time of the mastectomy. The patients come to see me in the office every single week, and I fill the expander using a needle and a syringe with saline to get it as big as they want it to be, or as big as possible to match the opposite side if it's a unilateral case. The problems or the negatives of that type of procedure is that they have to come into the office every week for the expansion, which takes up their time, which crowds up my schedule. The procedure itself can be somewhat painful, and it's slow because you can only put so much saline in at a time. It's like filling a water balloon. On average, we put about 50 cc's a week in with that technique. I was lucky enough to be part of an FDA clinical trial for the AirXpander, and the AirXpander device fills with a remote control. It has a little canister of CO2 about the size of a lipstick canister inside the tissue expander. And when the remote control is paired with the little canister, it releases 10 cc's at a time. Women can do that themselves up to 3 times a day, so they could really give themselves 30 cc's a day if they maximally fill, and fill in a matter of weeks.
Really?
Really. No needles, no time-consuming doctor's appointments. Patients get back to their work and their life a lot more quickly. It gives patients convenience, control, and comfort, and it's really been a privilege to be part of this study. The device was FDA approved and is now widely available throughout the country.
So I would assume then you have to counsel the individuals relative to the amount of expansion and things of that nature.
There's a lockout on the device.
Right.
People can't go crazy.
No,
we
I
wouldn't trust them to be willy-nilly.
No, we understand, but you know, what is in the eyes of the patient is not always within the professional skill or will of the physician. So,
Absolutely.
I mean, not that patients aren't smart, it's just that sometimes they may go just a little bit beyond. It's the old characterization of, I mean, I always say, you know, years ago, if you had a headache, instead of taking 1 aspirin or 1 Tylenol, you end up taking 2 or 3. That doesn't mean that you're going to get any quicker or better relief, you know. So that's the point I'm making.
Absolutely. So there's a lockout on the device. We teach patients how to do it. And I have a little key that I could put into the remote control to see exactly what they're doing, to monitor their progress. Absolutely.
Where does, when you do the surgical work, you do it in the OR?
Absolutely. And we do all of these surgeries concurrently.
Right.
The oncologic surgeon takes away the breast, and then the reconstructive surgeon comes in and restores it.
Well,
but it is a team effort and a multidisciplinary approach.
Well, that's the way it should be. That's the way it should be. Dr. Tranakas, I'm going to get back to you again. I know that you know there's one of the comments that we always hear relative to oncology is the when people talk about, in quotes, chemotherapy, that word, which is different definition today. But they always talk about they're going to lose their hair, they get sick, and they're nauseous, and they can't deal with it, et cetera, and the chemotherapy is worse than the cancer. That's what you hear. So I'm throwing it your way because I know it's not true.
It's not true. I mean, there are certain medications that will cause a lot of those symptoms, but also other medications that we've come up with to offset those symptoms have, you know, come into play. So chemotherapy is much easier tolerated. And again, with our more targeted therapies, we have fewer of those side effects because now instead of just killing a lot of normal cells as well as the cancer cells, we're actually targeting just the cancer cell so we can then minimize those side effects with our new medications. And so our targeted therapies really is the wave of the future. And I'm looking forward to, you know, many more new discoveries in the years to come. And even with the hair loss these days, we now have FDA-approved cool caps that look almost like the old-fashioned hair dryers, if you remember from the old-fashioned hair salons, where women used to sit underneath this device. Well, we have now, instead of heat, producing cold that then cools down the scalp, decreases the amount of cell division on those hair follicles, so as you're getting the chemotherapy, you have less likelihood to lose that hair.
Well, that's very, very interesting. So, and how long has eSSe plastic surgery been around our area?
Well, I've been in practice for 12 years.
Right.
I practiced off Las Olas for the first 9 of those years and moved my practice to S plastic surgery by Imperial Point 3 years ago.
Oh.
But I think just conceptually, like we say, it takes a village to raise a child. As a mother and a working mother at that, I rely on a lot of help to do what I do to raise my family. I think a patient needs to have that same perspective. It takes a village to keep a person healthy, especially when a patient gets diagnosed with a cancer diagnosis. They can't rely on just one doctor. They need an oncologic surgeon. They need an oncologist. They might need a radiation oncologist. They might need a plastic surgeon. It's that multidisciplinary approach and working together that the whole is greater than the sum of the parts.
No question. And you know, one of the things that you just mentioned where you're working, they just created some new hybrid ORs there, I believe, if I'm not mistaken.
Broward Health does
Right.
have hybrid ORs.
Right.
They're usually a combination of interventional radiology
Right.
and the vascular surgeons or the thoracic surgeons are working in those together to do surgeries more minimally invasively and more safely.
Well, that's the big thing with our folks out here. That the number one comments from our folks are, well, like I said, you know, really I mentioned the 3 cancers that they always talk about, but the things that our viewers always communicate on, they want to know about minimal invasive surgical techniques. They want to know about the new biologic genomic testing and therapies.
And the other important aspect is that innovation is happening right here in our own backyard. You don't have to travel someplace else to get the same level of treatment that you can easily get here.
Well, one of the things that I had a conversation with a very close personal friend of mine who you happen to know, Dr. Tranakas, and we were talking about a type, I don't want to get too close to it, a type of neurologic surgery. Mm-hmm. And all of a sudden now we're starting to see advertisements on television asking people to go to New York and go to here and go to there and whatever. And I said, wait a minute. I said, hold on a second. Has anyone ever spoken to Dr. So-and-so or Dr. So-and-so? Because I know who the doctors are that are doing the same thing right here. Right here. And our community of really of Florida and definitively South Florida has had an impressive increase in capability within these institutions called hospitals. And it's not only the elements of professional skill from people like both of you, but it's the aftercare. It's the coordination of, you said you're a psychologist in a sense sometimes. I definitely know about Dr. Tranakas because, like I said, I can tell you candidly, unfortunately, I've had to refer people to his, not to his service because he's a wonderful person, but because of the consequence of them having cancer. But the arm around the shoulder, the willingness to communicate is such a palliative thing. It's beyond belief. It's so important because the essence of care is that you are not just a skilled professional, but you are a good human being.
First and foremost.
Right? So I welcome you very much to this show. We're down to the last 2 minutes of this show. And I'd like to give you some time to talk very quickly about not only your Broward surgical units, the eSSe plastic surgical entity, but also about yourself, and go to it.
I'm a plastic surgeon at S, that's what eSSe stands for, S like the letter S, plastic surgery in Fort Lauderdale. I am a mom of 2 beautiful girls. I have a 9-year-old daughter and a 6-year-old daughter that more than keep me busy in my very limited free time. I'm married to a urologist named Ari Silverstein, who's in practice as well. So you mentioned prostate cancer earlier. And I feel like our whole life is exactly what you're talking about. Almost no topics of conversation are off limits in our house. Friends, family call 24/7 and ask all about breast cancer, breast health, prostate cancer, prostate health. And you know, part of why we both went into medicine is to help people and to disseminate this information. And it's getting harder and harder with restrictions from the government and electronic medical records. But the most important thing a doctor can do, as you've mentioned, is connect with the patient.
Absolutely. Well, thank you for being here.
Thank you for having me.
Dr. Tranakas, talk to me.
Well, thank you again for this kind invitation. And as you mentioned earlier, this is my 7th appearance on your show, and I'm very grateful for that. And the best thing that I can say is thank you for informing the public about important issues regarding their health for the South Florida area, and really, again, promoting the innovation and the technology and the good care that is happening right here in our own backyards.
No question about it. And you are at Broward Health, and you are obviously Broward Surgical Associates, correct?
Correct. I'm the managing partner for my 5-man surgical group.
Right.
We do general surgery, surgical oncology, laparoscopic surgery, minimally invasive surgery, and some innovative techniques when it comes to complex hernia repairs as well.
So again, I say take good care of yourself. Make sure you get those screenings. And remember, this show is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. See you.